Now, let's go back to what we talked about a little bit earlier, the NHS and face-to-face appointments, because, of course, we discovered through the course of this morning that the NHS has got a sustainability chief. Who knew? One of those ridiculous jobs that isn't really required in an organisation like the NHS. But the guy in question, who I will name shortly, was involved in an expo with Polly Toynbee, the Guardian columnist, in which he declared that it was actually great that face-to-face appointments with doctors had kind of disappeared during COVID because it was better for the environment. He actually said that they saved a load of carbon. Incredible. Absolutely ridiculous. Dr. Nick Watts more or less said that we should stick with this plan because the longer we keep face-to-face appointments off the agenda, the better we will be at getting to net zero. They saved 276 kilotons of carbon, apparently, last year. Let's talk to Dr. Bob Gill, GP and producer of the great NHS Heist. Bob, a very good afternoon to you.
Afternoon.
We've carried some very odd stories about the NHS in recent months. This one, I think, tops the lot. I mean, what on earth is the NHS doing even having a sustainability expert? Because, as people have pointed out, there's an awful lot of waste and stuff that damages the environment going through the NHS. Seems extraordinary that he would think it was a good thing that people can't see a doctor.
Yeah, I agree with you. Best medicine is practiced when you see a patient face-to-face, so you can examine the patient. But I'm afraid these so-called NHS leaders are, they have other objectives. You've mentioned privatisation. Well, we are currently in the sort of final phase of privatisation, and what that involves is eroding the quality of care that patients are receiving, which in due course destroys trust. So I'm with you. I think patients should have access to a doctor, to see them face-to-face, and require a diagnosis. The other agenda that is afoot is to replace doctors with non-doctors. Now, clearly, this increases risk to the patient because of the unknown unknowns. So you need patients to have access to doctors who are fully qualified, who can make a diagnosis based on a full assessment, including examination.
Yeah. Well, they seem to want to put more and more sort of power into the hands of the pharmacy at the moment, don't they? And lots of people will probably tell you, and certainly I've seen it with my own eyes during the pandemic. If you went into a chemist, there was always a queue a mile long at the pharmacy, presumably because the pharmacy doesn't have enough staff or something, I don't really know. But it doesn't ever look like an easy thing to do to get to see a pharmacist.
Yeah, again, this is diminishing the role of the doctor, it's diluting the quality of service available to the patient. And let's not forget, pharmacists, commercial pharmacists, have a conflict of interest. They want to sell you products which you might not need. Now, fortunately, general practice has been protected against that conflict of interest appearing within the doctor-patient relationship. I do not profit out of prescribing certain things for my patients. But that is not true for commercial pharmacists. So the downskilling agenda, the substituting of doctors with non-doctors, and introducing barriers to access is all part of the government's attempt to complete their privatisation agenda, I'm afraid.
But what would be the point of that?
Well, the point is to hand over as much public service money, budgets, to private corporations. We've seen that with the railways. We're subsidising profits and shareholder dividend for railway shareholders. We've seen that across the public sector. This is, the key pillar of neoliberalism, is to hollow out public services and make as much public money run through the hands of intermediaries. That includes corporations who provide healthcare, and more a bloated management bureaucracy imported from America, dominated by the big four accountancy firms and private insurance companies that are driving up costs and pulling money away from patient care.
But isn't part of that problem the NHS management structure itself, though, which is nothing to do with the government? It's everything to do with the NHS. I mean, for example, this guy, Dr. Nick Watts, who's the sustainability chief, he wasn't appointed by Sajid Javid, was he?
Well, if you look at the history of the NHS, there's been successive legislation. It goes back to the 80s, the Griffiths report, where he created a huge bloated management structure, which is required if you're going to outsource NHS function. if you're going to do contracting, contract monitoring, you need a bloated administrative structure. So that was introduced by government in 2012. The government bill separated the NHS from government control. But all the appointees, these leaders do not come out of thin air. They are appointed. And if the NHS leadership is not in lockstep with government policy, they are replaced. So there is no independence in reality. This is very staged managed. The leadership of NHS England is appointed by government, and they make sure the leaders down the line are following the script.
It sounds a bit like a conspiracy theory, but I'll go along with you for a while. Where's the end point then?
The end point which we're approaching is to turn the NHS into a logo and a budget. This budget will be controlled by the private sector. Becoming law in July is the creation of integrated care systems, which are modelled on the American managed care system, which effectively gives public budgets over to insurance companies who have a fixed budget from which they can extract a profit. And the way they do that is through denial of care.
Well, I've lived in America, and I can say this, that the system that they had in place in America was a lot more efficient and better managed than anything that we do.
Yeah, but the facts are that it costs twice as much and has worse outcomes. Lower life expectancy.
No, it doesn't. That's not true. They have much better outcomes in cancer care. They have much better outcomes in detecting cancer and in preventable disease management. They have much better outcomes than we have.
Well, how do you explain lower life expectancy, higher infant mortality, higher maternal mortality at double the cost, with 30 million people without insurance, without access to care, and with those who are insured?
Because they have a system in America which is not a safety net system. They have a system for care if you have no money. They do, but they also have a very, very bad problem with inner city poverty in some parts of America. But it is not overall an infant mortality issue, and neither is it an issue of life expectancy. You know, if you are poor in America, you probably die younger. But, you know, you could say the same about this country.
Yeah, but the overall life expectancy in this country has been a lot better. It's approaching the American levels because we're copying their system. And let's not forget, 1 in every $3 spent on healthcare goes in administrative costs and chief executive bonuses and profits for shareholders.
And how much of the money that we spend on the NHS in this country, which is effectively 20% of everybody's income, you know, that doesn't go to clinical care either, does it?
I agree, and as I've set out...
But it never has.
I've set out, we've had 4 decades of marketisation. When Thatcher took office, the administrative overhead for the NHS was around 3%. Estimates in the mid-2000s that it approaching 14%. So that's a 10% increase. And, you know, best guess estimates, because the government doesn't like to record these figures, would be about 20%. And we're heading to the American overhead, which is 36%.
Sounds like it was all Tony Blair's fault, Bob.
Well, he played his part. I've got no doubt. You know, there's been a cross-party consensus in this betrayal that I'm outlining to you.
OK. Interesting. We must talk again. Dr. Bob Gill, thank you very much indeed. GP and producer of the great NHS Heist.